Good afternoon, everyone. Welcome. I see several folks still coming into the virtual space, so we'll just give them a minute. Okay. Well, welcome to today's national webinar presented by SAMHSA's GAIN Center with the support of SAMHSA, which is the Substance Abuse and Mental Health Services Administration. And our webinar today is Update from the Field, Crisis Response and Co-Response to Support Individuals Experiencing Mental and Substance Use Disorders. And over the years, the GAIN Center has presented a number of webinars on these topics. So we're excited to provide this update today, really highlighting two communities that are expanding their continuum of crisis response and co-response to ensure the right response to the call for service. And so what we're seeing is more effective use of resources, also lightening the load from critical resources such as law enforcement and enabling other groups to respond to appropriate calls for service while also retaining the involvement of law enforcement where it's needed. And so today we will hear from two communities represented by Lee Mazur and Candice Hashimi, and I will introduce them shortly. First, I have a couple of introductory items to review. I'm Dr. Melissa Stein, a Senior Project Associate at Policy Research Associate in SAMHSA's GAIN Center. And you will see an icon for a chat box at the bottom of your screen. Please feel free to use that chat box to introduce yourself and share where you're joining from. I am joining from a cool but sunny North Carolina today. Before we start our presentations, I'll just cover a couple of items. First, the views, opinions, and content expressed in this presentation and discussion do not necessarily reflect the views, opinions, or policies of the U.S. Department of Health and Human Services. And we do have a Q&A pod you also will see that icon at the bottom of your screen. And there, feel free to enter any questions you may have throughout the presentations. And at the end of the presentations, we'll cover as many questions as time permits. You'll also see a couple of polls pop up. You should have just seen one pop up right now. Just select and submit your responses, and we really appreciate your participation. The webinar is being recorded today, and slides will be disseminated to all registrants following the event, and we will also notify you when the recording of this webinar is posted to SAMHSA's YouTube channel. And we will be providing a certificate of attendance for download at the end of the webinar. Please note that this certificate is for your personal portfolio. We are not able to issue CEU credits. We do have ASL interpretation today. Our interpreters for today are Dave Gratzer and Paige Bixby. We also have live captioning for today's event. To view live captioning, click the Show Captions icon at the bottom of your screen. And now I'd like to introduce our speakers for today. Lee Mazur is a leader in community-based crisis response and public safety innovation. She currently serves in leadership roles within the City of Durham's Community Safety Department, where she oversees alternative response programs, including the deployment of specially trained teams to 911 calls and co-response initiatives. She also led the creation and implementation of the Office of Survivor Care, which provides support and coordination of services for individuals impacted by gun violence. With a background in social work, emergency services, and behavioral health, Lee has extensive experience building and managing 24/7 crisis systems, developing quality assurance frameworks, and strengthening cross-system partnerships. Her work focuses on advancing fair, person-centered responses to behavioral health crises. Candace Hashimi serves in a leadership role within the city and county of Denver, Colorado, where she oversees the Support Team Assisted Response Program, also known as STAR. In this role, she guides strategic planning, program development, and program operations to ensure high-quality, community-centered crisis response services. She is a licensed professional counselor with more than a decade of experience in the mental health field, specializing in crisis intervention and systems-level crisis management. And her expertise is rooted in work across crisis stabilization units, walk-in centers, emergency departments, inpatient psychiatric care, the statewide crisis hotline, and both traditional and alternative crisis response teams. Candace brings a deep foundation in crisis response, behavioral health interventions, and collaborative public safety and public health systems. She's committed to strengthening and advancing crisis response models that are efficient, effective, fair, and designed for long-term sustainability and growth. So we are really excited for you all to hear from both of these presenters today. And I'd also like to just touch on who is joining us today. Thank you so much for introducing yourselves in the chat. Love to see all of that and to see who is here from where. We do see that about 44% of you joining from urban locations, but that's followed by about 32% of you joining from rural locations. So that's really wonderful to see. Welcome, everyone. We do see a few folks coming and identifying that they are living on tribal lands, such as a reservation, pueblo, or Alaska Native village. And then finally, looking at roles and who is joining, we do see, let's see, I believe about a majority of you, 32%, joining from community-based provider organizations. No surprise there. We do also see about 12% of you joining from crisis services, EMS, and 18% of you joining from government and policy. So welcome, everyone. Thank you so much for taking time out of your day to hear about these wonderful programs. And without further ado, I'm going to turn it over to Lee Mazur to begin the presentation on Durham, North Carolina's work. Lee.
All right, thank you so much. I appreciate that introduction and am super excited to be here with you all today. Again, my name is Lee Mazur. I'm going to talk with you guys about the Durham Community Safety Department. As noted in my introduction, I have a background in social work and have spent many years in community mental health and transitioned into more of the government sector about 4 years ago when I came to the Community Safety Department. So if anyone is familiar with HEART, HEART has kind of its own all-encompassing group of programs, but we are housed within the Community Safety Department. And the Community Safety Department is a new department created within the city of Durham about 5 years ago. And at that time, there were about 13 employees dedicated to figuring out what HEART was going to look like, what types of programs it would encompass, and how we would respond to folks in need in the community. After a year of very careful design, which I'll talk with you guys more about soon, we advanced to about 20 employees within the 4 programs of HEART and our administrative team. After the first year, we expanded citywide. So initially, our services were just in a smaller catchment area within the city of Durham. But as you can see in year 3, there was a huge expansion, and we were able to get to additional calls throughout our programs. As you can see, the last 2 years have been another kind of rapid expansion for our department. I'm not going to touch on kind of the specifics of each individual program, but I did want to provide you all with an overview of our department scope. So we started as HEART, which are the four alternative response programs that I'll talk with you more about, and have since branched out to providing care for street outreach teams, which specialize in working with unhoused folks. We have Welcome Home, which is a program dedicated to working with individuals returning from incarceration. We've got our Office of Survivor Care dedicated to working with folks who've been impacted by gun violence within the city of Durham. Our Familiar Neighbors team, which is our team of folks who we interact with pretty frequently in the community. It's a special team dedicated to just working with these folks really intensively. And then additionally, we have our harm reduction pilot, which is a grant-funded pilot, and it's dedicated to focusing work towards individuals who are using substances in the community and engaging with them, building relationships, and providing them with support as needed. So again, I'll narrow the scope of this conversation to specifically talk about HEART, which is the Holistic Empathetic Assistance Response Team. And it's an alternative response program that, again, started about 5 years ago. And we have been responding in field to calls since July of 2022. And we've responded to over 40,000 calls in that time. The goal of this work is really to individualize care. So when we're responding to 911 calls, what does this person need in the moment? We're able to take a little bit more time on our calls and pinpoint any needs of that person, really kind of tailor our support. Does this person need to be transported to another location? Does this person need follow-up care? Are there referrals we can put in place? But really tailoring the type of support that we offer on each interaction with the individuals that we're working with. And from time to time, you may hear me refer to folks as neighbors because that is the term that we use for individuals that we work with in the community. So I just wanted to provide that knowledge as well. So historically, HEART has consisted of four programs. We have our crisis call diversion. I'll briefly go over these and then go into a bit more detail in a few minutes. But our crisis call diversion program is where we have a clinician who's embedded within the 911 call center. So you're going to call 911. You're going to get the same response you always would by a 911 call taker. If that call then has a mental health or social and emotional component, the call taker then transfers the call to our clinician in the center, and they're able to provide support over the phone. We also have our community response teams, which is a team of 2 to 3 individuals who are dispatched from the 911 call center to calls that have, again, a mental health or social and emotional component to them with no overt, weapons or danger noted in the call notes. Additionally, we have our co-response team, which is a team of 2 individuals. They are, it's one of our clinicians who's partnered with a Durham police officer. And our officers are a special pool of officers that we work with, and they're dedicated to specifically working with our responders on higher acuity 911 calls that may involve violence or a weapon. And then we also have a follow-up team. So our clinicians, our peer support specialists, and our EMTs can put in referrals to our follow-up team or care navigation team if they feel like they've interacted with someone who needs some additional care and support. And that's our care navigation team. So as you can tell from that first slide, we have grown an incredible amount in a very short period of time. And so we've been very intentional about staffing our department and the folks who are responding to 911 calls. And all of our staff are generally city staff, fully funded city department. So similar to folks in fire, folks in PD, no one is contracted. We're able to employ folks specifically as city employees. But we do ensure that they are properly trained. All of our staff are going through an 8-week academy in which they're doing kind of a combination of shadowing in field with our existing responders, as well as typical classroom-based training. We do have one grant that actually ends next month for our involuntary commitment team that has 2 FTEs, and I'll get into a little bit more of the specifics of that later. Generally, our teams are made up of clinicians, which they're coming with a background in working in acute settings. So be it um, a inpatient psychiatric unit and a hospital, we're really looking and targeting our hiring outreach efforts for folks with acute experience because that's the type of calls that we're going on when we're in the community. But the clinicians are de-escalating, they're able to diagnose as needed, and they're approaching every call with a trauma-informed lens as their training would support. We also have EMTs on our team, and they're typically doing a fair amount of wound care that for folks who may be resistant to going into the hospital setting to get wounds treated. They're doing a lot of medical education about what may happen if folks, continue to go untreated for certain things or how medications may interact with one another. They're also able to provide Narcan on scene as needed. There's been times where we've interacted with folks who have overdosed on scene, and our EMTs have stepped in to provide support in those moments as well. And additionally, we have peer support specialists who are folks who are coming to us with lived experience of either having maybe a mental health diagnosis themselves, having previously been unhoused, having some previously having been incarcerated, but really having a different lens and a different ability to approach the neighbors that they're working with. And we have seen folks who have been incredibly resistant to engaging with our clinicians or our EMTs because they feel like, oh, you don't understand what's going on. You couldn't possibly know what it's like to be in my position right now. And our peers are able to have a much different type of conversation as they discuss kind of their background. And it has really changed our ability to connect with folks. So that was kind of an overview of who is in the department. I want to talk a little bit about how we are dispatched. So we are fully integrated into the city's 911 call system. So our responders carry police radios. This is a picture of actually the older ones. We've upgraded since this time, but we operate on the same channels as our fire departments and our police department and our EMS department within the city. So we can all hear each other on the radio. We can request support from one another as needed. And I think what has been helpful is no one has to memorize a new number to contact us. And it's up to the CAD system in the 911 call center to triage who is responding to what call. So it takes a lot of the energy and brain power from the call takers to have to decide, is this appropriate for heart? Is it more appropriate for the police department? Instead, it's all programmed within the CAD system, which calls are appropriate for our teams. And here is a list of which calls are appropriate for our teams. So one thing we did during that first year of planning is we had regular meetings with our partners in the public safety portfolio, so including our representatives from the Durham Police Department, the Durham Fire Department, EMS, Alliance, which is our local MCO, representatives from like schools of social work around the area, to really analyze what calls were appropriate for our teams to respond to. And the unique thing about those conversations is everyone was able to identify their, concerns about certain types of calls, having an unarmed response. And we really went to the data for that. We did, prior to the creation of the department, there was a 5-year study on 911 calls within the city of Durham and incidents of violence that occurred on those calls, arrests that occurred on those calls. And so we reviewed that data, and that really helped inform those conversations with our partners about what types of calls actually lead to the most violence or most arrests, and which calls don't, because there was a lot of misconception about that as well. So ultimately, we came up with the call types that you'll see here. And when I say call types, I mean when someone calls into 911 and, let's say I call in and I say, there's a man in my store, he's refusing to leave. The questions that I ask are then coded in the system, and it's going to release a call type at the end of that call, and that's going to be a trespass call. So anytime someone calls in, there's a certain call type that's identified at the end of the call. So for us, our clinicians embedded in the call center automatically get transferred two types of calls, and that's mental health crisis calls and suicide threat calls. And they are, um, while those are the only two types they automatically get transferred, there's a lot of other call types that the call takers have the ability to transfer as well if they think this person might need additional support. And you'll see this other list for our community response team. And third, you'll see the list for our co-response team. As you can tell, our co-response team is responding to calls that involve violence or a weapon. Again, that is because we do partner with law enforcement on those calls. So they are there to provide support as needed. So this slide goes into a little bit about what I just talked about, kind of our data informed and collaborative approach to building the program in itself. So we also worked in really close partnership with other cities who at the time were doing something similar. Shout out to our partners at STAR, also on this call, and Albuquerque. So we have worked and continue to work really collaboratively with those folks as the field continues to grow. I'll talk a little bit more about our crisis call diversion team. And again, this is where we have 3 FTEs dedicated to this position who work from 9 a.m. until 9 p.m. in our 911 call center. They're reporting to work most days at that location and coming to our office as needed for training and supervision. The goal of CCD is to connect callers with care and support the moment that they call. As soon as that call is transferred, our clinicians are able to de-escalate over the phone as needed. They're able to provide resources and support, and at times divert any sort of in-person response if that's not what's needed in the moment. An example I always give for this is let's say a parent is calling into 911 and they're saying, my child is refusing to go to school. They seem like they're depressed. They're not willing to talk to me. I don't know what to do. In that moment, it's not necessarily appropriate to send fire. It's not appropriate to send the Durham Police Department. However, if there's no acute safety concerns, we also don't need to send our CRT or co-response teams if that clinician can support both the youth and the parent over the phone and ensuring that they get into one of our local 24/7 walk-in clinics that day. And they can also follow up with that family later in the day to ensure they receive the support that they needed. And to the right of the slide, you can see our average kind of response times for CRT, or I'm sorry, for CCD, and the number of minutes that they're typically on the phone with folks. And now I'll transition to talking about our community response team, which again is that team of 2 to 3 individuals, inclusive of a combination of a clinician, an EMT, and a peer support specialist. They are responding to mental health calls that may be overtly mental health or just quality of life concerns. And the goal of these interactions is to really just figure out whatever that person needs in the moment. If it is kind of a trespass call that the person has, someone has called into 911, why is that person trespassing? What is the need and the unmet need in that moment, and how can we be a support? Can we transport them to another location? Can we reconnect them with the shelter system within the city of Durham? And what can we do to tailor our support to them? If it's a mental health crisis, how can we de-escalate the situation in the moment? Can we safety plan with that person enough to remain in the community with whatever their natural supports are? Or can we support this person in transporting them directly to one of the walk-in clinics here or the hospital if that's what's needed? These calls, as you can imagine, really range depending on the situation and the hour of the day. So a wide variety for that. And to the right, you can see similar metrics of our overall number of responses up at the top, the average time that it takes for our responders to get to the scene. So that's the 12 minutes and 45 seconds. So that's from time of dispatch to arrival on scene. And then you can see the 35-minute mark is about how much time our responders are spending with neighbors on average, for a total of about 47 minutes per call. We have our co-response team, and this is where we have 6 clinicians who are dedicated to partnering with a CIT unit or a co-response unit within the Durham Police Department. And they're specifically trained officers who have received that CIT training and advanced training in mental health and crisis. And they are primarily responding to the higher acuity 911 calls that may involve violence or a weapon. And this partnership was created to ensure that we were able to have a response on the most acute types of calls. So our partners in law enforcement are there for safety and intervention and verbal de-escalation, because they're certainly trained to do that as well. And our clinicians are there to ensure that there's continued de-escalation, but also a different type of support available on the call. And to the right, you can see the metrics. Similarly, for our co-response team, they're spending on average about 52 minutes on scene in comparison to that lower number for CRT. And I really attribute that to the fact that they're responding to a lot of involuntary commitment calls. And those calls on average take about 2 to 3 hours because transports are typically involved. Okay. We also have, and this is our newest program, and it's our involuntary response team. I'm going to give you guys a little bit of a background that's specific to North Carolina about our involuntary response team. But generally, this unit pairs a licensed clinician with an EMT to respond to calls in which an involuntary commitment has been taken out. In the state of North Carolina, if you are concerned about a loved one and you feel like they need to be involuntarily committed, you then go to the magistrate's office and petition for an IVC. The magistrate then makes the determination as to whether or not they're going to issue that transport order for the person to go to the hospital to be further evaluated for that first examination. So that is historically how it has worked here in Durham. With this new unit, we now have the ability to, after the magistrate has issued that transport order for an IVC, we can arrive on scene and do that first examination in field to determine whether or not that person does indeed need to be transported to a secondary location because they're a danger to themselves or others, or if after further examination and safety planning, that person does not need to be unnecessarily transported to a hospital setting, and they can remain in the community safely. So again, this is very new work. It's our newest program in the department, and it's been a real privilege to be able to do that. The goal is truly just to provide the individualized support of the neighbors that we're working with and making sure that they get the help that they need. And if they don't need to be transported to a secondary location, they're not. Okay, my last couple of slides are just going over a couple of program metrics. These are questions that we most often get, so just gonna put it out there for everyone to kind of look at now. After every single call, our responders, we use an EHR system called Gelada, but our responders take a survey within that system that measures whether or not they felt safe on that call. And over 99% of the time, our responders feel safe on the calls that they go on. We are calling for emergent backup less than 0.5% of the time that we are on scene. And I want to differentiate this in that this is urgent police backup, 0.5%. We are at times contacting the police for other things if someone, if someone requests their presence. We are generally viewed as helpful by police. One of the folks evaluating our department has surveyed the police department, the Durham Police Department, and it was identified that 94% of officers view us as helpful. And we are, I'll get into this in a moment, but they are often requesting our support on calls as well. Does HART change transportation rates? If HART is on a call, it is 5 times more likely that that person is going to be transported to a non-hospital care setting. And have any of our responders ever been injured seriously on a scene? And the answer is no. In the 5 years that we've been operating, that's not luckily anything that we've had to worry about. Officers this year so far have requested support from the HART responders about 400 times. And generally, we're saving police hours to do work, to do other types of work, and on average about 8,000 hours per year. And we do, the data does show that we do, the calls that we are on, there are fewer arrests on those calls by at least 4 times. So this is another example of, it kind of just pinpoints the times in which we might call the police for urgent backup. And an example of this may be if, we're on a welfare check call and, unfortunately someone is deceased and we arrive on scene, or if there is some like verbal escalation on calls and we feel it would be better served if police were there for safety and support, we'll call them in those situations as well. And the graph on the right is kind of identifying CRT units resolve calls on scene without the need for transport over 70% of the time. So while we do have the ability to transport, and we'll absolutely do that when necessary, it is not always necessary. And this is kind of just providing a more detailed look of how we are able to save and free up DPD for other resources and other needs in the community because we're able to respond to calls independently without them. And showing the increase and frequency in which we're requested by the Durham Police Department since our inception. As you can see, it's continues to trend upward. And lastly, this is just an overview of our transportation rates, specifically to DRC, which is that 24/7 crisis center aimed at providing support to individuals who are voluntarily seeking treatment. And then on the right, we have arrest rates in comparison to when HART is on calls, which is in the purple, and in comparison to when we are not on calls, which is the blue. So that was a lot of data I just showed you. A lot of that came from the external evaluations that we've had for our department. In particular, we've partnered with Duke and the University of Michigan, noting a couple of additional factors there. There's about a 58% reduction in crime reports and a 56% drop in arrests for incidents handled by HART in comparison to similar police-only responses. We also have about a 6-minute our response time is about 6 minutes faster than police-only response as well. And it was noted that there's a $902 per person or per response driven by reductions in crime-related expenses and enforcement needs. And you can see the 2 of the studies here. I'm happy to kind of send those out as well as needed, but they are publicly available as well. Gonna pass it over to my partner now.
Thank you, Lee. And thank you for the introduction, Melissa, in the beginning. I'm going to talk about the different response options that we have available here in Denver. We do have a variety of different outreach and different response options throughout the city. And there's two different ways of getting in contact. So there's the 911 and then through 311. And today I'll be focusing on the options that are available through the 911 system. Um, it's helpful to start with a little bit of history and background. So, in 2016, we launched the Crisis Intervention Response Unit, which I will talk a little bit about or a little bit more about in just a couple minutes. But to give a brief overview, that is our co responder unit here in Denver, and it is housed under the Denver Police Department. And pairs a behavioral health clinician with the Denver police officers who are working patrol. Denver does not have a specialized team of officers like Durham does, but the officers are all CIT trained. So the clinicians ride with the officers. Right around that time, I think when the clinicians were riding with the officers, they were identifying that there are a wide variety of calls that they were responding to that did not necessarily require a law enforcement presence. And at the same time, we were getting a huge push from community members to have a different response option that exists. So in 2019, a few of those clinicians, the Denver police chief at the time, as well as other individuals from the city and community advocates who were a big support and a big part of the program development, all went out to Eugene, Oregon to visit the Cahoots program and learn more about different ways that alternative response can exist. And so they all came back and started planning the development. And in 2020, STAR was born. And we are very excited that this year we will be launching a pilot of a 911 crisis diversion program as well. So, as I mentioned, the co-responders or the crisis intervention response unit, I do not oversee this team. It is housed under the Denver Police Department, but we work very closely with one another. I think one of the things that might be helpful to mention is here in Denver, the various programs that we have all are housed in different departments within the city, but we all collaborate and work together very closely. So the Crisis Intervention Response Unit is under the Denver Police Department, and as I mentioned, pairs a clinician with a patrol officer from Denver Police. They are 7 days a week and operate roughly from 6 a.m. to 12 a.m. And they do have 2 dedicated clinicians per police districts. Here in Denver, we have 6 police districts. And the purpose and the reason why this program was developed in 2016 was really just to support an overall effort to expand law enforcement and bring a clinical lens in supporting individuals within the community who are calling out to 911 and adding a different option for people who are experiencing a variety of different crises and in need of a different type of support. The Support Team Assisted Response Program, also known as STAR, which is the program that I oversee, is a civilian response team similar to Durham's CRT. So we pair, it's a 2-person, we pair a behavioral health clinician and a paramedic or an EMT. And then we do have a community network of about, I believe it's five or six community organizations who provide case management and follow-up services and connections to ongoing care and treatment. We are also 7 days a week and operate from 6 a.m. to 10 p.m. And a citywide response. And really, our purpose is to be a different and alternative response to situations that don't require police, EMS, or the fire department. And we are dispatched through Denver 911. A little bit about our program expansion. So, as I had mentioned, in 2020 is when we launched the STAR program. It was initially intended to launch in January of 2020, but a little thing called COVID happened and that kind of delayed. So, in June is when we were able to launch the program. It started out as a very small program through the pilot. We had one unit and we were working in one district, and in fact, in a very specific area, not even, I think, the entire district, our downtown area in Denver. And we're operating Monday through Friday from about 10 to 6 p.m. And then in 2021 and 2022, we were able to expand to serve as a citywide response. We were able to add additional vans, and we're operating with 5 units per day, and expanded our hours of operations from 6 a.m. to 10 p.m. And also to 7 days a week. And we also added our community partner network, which I will talk about in a little bit, but that is our network of providers who provide case management and connection to wraparound services for us. In 2023, we expanded to 8 units per day and stayed again, still citywide, and kept our hours of operations, which is still the same. And in 2026, this year, in the summer, we are excited to be bringing in our clinical services of our responders in-house within the Department of Public Health and Environment, which is where the STAR program is housed. Up until now, we have been contracting out our services. So the program is a city program, but we contracted with our community mental health provider here in Denver to provide our clinical services, and then our hospital health authority for our EMTs and paramedics. We're currently in the middle of an RFP, just per city rules for the medical services, but are excited to be bringing the clinical services in-house. So just some pictures for you of our vans. All of our vans were designed with our the community advocates, who are also part of a community advisory committee that we meet with once a month. We really value community voice and want to make sure that our decisions and our operational approach is, guided by community voice. And so our vans, we had a lot of feedback from our advisory committee, and this, is some pictures of our vans. They are all ADA compliant, and we do have a wheelchair lift in all of the vans. That captain's chair that you see in the picture in the top corner, that was done intentionally so that when we are transporting individuals, the clinician can sit in the back and be able to turn the chair and face our clients and, continue supporting them through the transportation. And then I'll talk a little bit about our follow-up care and case management. So, as I mentioned, we do have a network of community agencies that we partner with. We partner as the city. We have a contract with one organization who then oversees the other 5 organizations. And when our responders make contact with someone who is in need of really anything additional beyond what would be provided to them on scene, any sort of resource navigation, any connection to services, they submit a referral to our case management partners who then are following up within a 24 to 72 hour period and they conduct a needs assessment, and then they will work with people as long as it's needed. I think that's something that's unique to our program is our case management services, and what our STAR Community Partner Network does really is ongoing. And the purpose of that was that, we identified this gap between when someone experiences a crisis and then when they're actually connected to services. And also sometimes, different services exist, but maybe aren't able to meet all of the needs of an individual. And so that's why we do have case management services. And then each of those community organizations do specialize in a variety of services and are able to, get people in and connected to those services. So this slide, we're going to talk about kind of how Denver 911 triages or, handles calls that come in. STAR is viewed as the 4th branch of the response system. So when someone calls into the 911 center, all of the calls are handled by what we call universal call takers, and they're asking the same questions for any person who calls in, whether that's 911 or the non-emergency line. And then based on those questions, they determine that call type or the nature code, like Lee had also mentioned. And we have a set of specific nature codes that can be appropriate for a STAR response, depending on, other information that's provided. Really, we're going out on a variety of calls that span from behavioral health related crises to really anything that just doesn't require law enforcement or any of the other response options. So once the call has been processed, the call takers will flag the call for STAR. And right now, we are dispatched by the police dispatchers. The 911 center here in Denver is not part of the police department. It is completely separate. Department within the Department of Safety. And so the call takers can ship off the calls either to the police dispatcher, EMS dispatcher, or the fire dispatcher, and everyone's kind of in the same building. And so once it gets to the dispatcher, because they have flagged the call for STAR, the dispatcher will know to request STAR and send the call to them. And as I had mentioned, the co-responder team here in Denver, just as part of DPD's patrol. And so they're not, that's why they're not specifically listed here. So, but the dispatchers can call them. And, if there's a call that's appropriate for a co-responder that's not appropriate for STAR, the dispatchers do request the co-responders. Just very brief data overview over the past few years. As you can see, we've had a steady increase. What The STAR eligible means that's what I was mentioning. So when a call comes in that is appropriate for STAR, meaning there is no life-threatening emergency, no need for an ambulance, there's no active violence or involvement of weapons, that call gets flagged as a STAR call, and that's what we refer to as STAR eligible. And then it can be dispatched to a STAR team. One of the things that I always like to point out when we look at this slide here is that, as you can see, a good percentage of our responses are to the calls that are eligible for us, but obviously the total responses are higher. And that just means that we are being requested by other first responders. So police, EMS, and fire are regularly requesting us. And that tells us that we are definitely a needed resource and, are all able to help one another. So really the goals and overall purpose of the STAR program and really any of these behavioral health programs that we have, these response options within Denver's 911 system, is to reduce any number of unnecessary involvement with the criminal justice system, as well as the emergency department. I think traditionally, first responders have always relied on the hospitals for people experiencing anything related to behavioral health or anything psychiatric related. And what we know is that that's not always the best place for them to go. And so we're making an effort to really support the system overall, which includes the hospitals. Here in Denver, for the emergency mental health holds, it's a little bit different than in North Carolina. So here, law enforcement, licensed clinicians, as well as physicians, are able to author a mental health hold after they conduct an assessment if they feel that an individual is meeting criteria for imminent danger to self, others, or presenting with symptoms of grave disability. And so our teams are able to do that. We do have licensed clinicians on both STAR and the co-responder teams, and we're able to bring the same evaluation that's being done at the hospitals to the scene and do that and determine the most appropriate level of care with the least restrictive lens, so that we're not taking someone to the hospital who's likely to be discharged in a couple of hours without true connection to the resources that they really need. So a little bit about the 911 Crisis Diversion Program, which is our newest crisis response option that will be available through 911. We're very excited to launch this. We are in the hiring process, and shout out to Leave, who has been a tremendous support throughout this process. Since they had done this before us, we've been connecting, and we're very excited to have this program. The reason for this was really to bring a clinical lens to the 911 center and be able to enhance and better support the existing crisis response options that exist within the 911 system. Which includes STAR and the co-responder team, and to be able to provide immediate support and crisis intervention over the phone, and really to divert from an unnecessary in-person response. So when we were working on and developing the program initially, what we found is that a good portion of the calls that both STAR and the crisis intervention response unit calls that they were handling were over the phone only and not an in-person response, which, we know that STAR is not able to get to all of the STAR eligible calls. And there's a lot of things for, the co-responders to support with as well. And so this is really meant to help us be more efficient and to handle the calls that do not need an in-person response over the phone out of the 911 call center, and to then be able to dispatch the responders to those calls that do require an in-person response, and overall increase our ability to support the Denver community. Oh, I forgot to mention, one of the other things that we're excited about is these clinicians out of the 911 center will also really be able to support and help us increase the calls that we're flagging for STAR, or calls that, are not maybe an appropriate call for STAR, but need a co-responder because, traditional call takers and dispatchers are not necessarily, they don't have that training to be able to specifically identify. So sometimes, we do have protocols and policies for them. And I think traditionally speaking, they're very used to that, worst case scenario. And I think that at times there is a mentality of law enforcement, like that's just where their thoughts go. So yeah, we're excited to increase the number of calls that we're marking as STAR eligible, and to really increase our ability to send the most appropriate and right response based on what's going on. We did have a third-party evaluation that was conducted with the Urban Institute, who essentially found that there is significant impact on reducing criminal justice involvement for both the STAR program and our crisis intervention response unit. So for both programs, we did run into a lot of challenges. I just want to know, I think it's important to know, we work within a lot of different systems, and especially because we were contracting our services out, we weren't all documenting within the same system. And so that always creates some challenges when it comes to data collection. And we're excited to streamline some of that by bringing the clinicians in-house. But at the time that this evaluation was conducted, we had to use the information that we had through our different providers. And so there were some challenges, but essentially, what the Urban Institute report found is that people who have contact with STAR were 16% less likely to have any police encounter the year following that STAR interaction, and 16% less likely to experience any arrests in that following year as well. And then for the crisis intervention response team, they found that individuals who encounter our co-responders are 15% less likely to be arrested the following year. And then reductions were observed in police contacts and bookings through, although they weren't as significant as STAR statistically. However, we did see a reduction still. So and I believe that is all I have. Thank you.
Okay, wonderful. Thank you so much, Candace and Lee, for sharing about your programs. I think that our audience got a lot out of it. So I want to go right to the questions. And as we are having these conversations, feel free to drop any additional questions in the Q&A pod. So let's see. Lee, you provided a pretty good kind of a screenshot of the types of calls and the process that you all took to determine where calls went. Candace, was there any similar conversation? How did you all decide what types of calls would go to co-response or your crisis response team, STAR? Um, you, what more could you add about that process?
Yeah, very similar to what Lee had shared. We use a different system within our CAD. And so it is really up to our call takers to flag them. But we do have a set of nature codes that we've identified. Sorry, I'm getting an Amber Alert. um, oh my gosh, I apologize. So we do have a set of identified nature codes that we feel have the most types of situations that would be appropriate for STAR. And so the call takers have a set of protocols based on if someone calls and based on what's going on, and it fits into one of those nature codes where it could be appropriate for STAR, then they're really looking for those disqualifiers, which, as I mentioned, really is involvement of weapons within the situation, active violence, or a medical related emergency. So, for example, and I believe this was also on one of Lee's slides, we unfortunately on STAR are not able to respond to overdoses. That is a medical call that requires an ambulance. And even though we do have a medical provider on the van, we're not, the vans are not equipped as an ambulance. However, we can support individuals who are under the influence. We carry Narcan, and our medical providers are able to triage. So if we happen to show up on scene and there is a medical situation, they're able to triage that and offer treatment and care until an ambulance gets there. But we're not being dispatched to those calls.
Okay, great. All right. Let's see. A couple of folks have brought up 988 and a huge initiative across the country. And that wasn't necessarily the focus of our webinar, but would either of you feel prepared to share, what is that interaction with 988, if there is any? Lee, would you feel comfortable starting us off?
Sure. So we are not directly dispatched by 988. There are certainly similar programs throughout the nation that are directly dispatched through 988. Our department itself, those referrals have to come from the 911 call center. So for instance, if a 988 operator felt like someone needed an in-person response in Durham, they would transfer that call to the 911 call center in Durham, and then that call would be dispatched as appropriate according to its call type. So it's very likely and possible that our team would respond to those calls, but it would not happen every time because, again, it depends on what call type comes out.
That's great that there's still that connection, that 988 knows they can still push them over to 911 and still be linked with your services. That's a really great connection there. Candace, how do you all handle that in Denver?
Yeah, so we do work with 988. Our Denver 911 Center does actually have protocols for very specific types of calls that might meet criteria to send to 988. And it's usually it's a very specific set of protocols, and there's very few calls that are usually transferred. And then of course 988 in Denver or in Colorado, they do have a variety of different mobile crisis teams that are often appearing to mental health clinicians, but they also have very specific types of things that they're able to respond to. And so in a lot of situations, they're actually sending calls to 911 to have one of the response options within 911. And, we're able to then dispatch a STAR team or co-responder depending on scene safety risk. So, but we do partner with them definitely.
That's great. Okay, so there were a few questions that came in regarding funding, and I think I warned you on our planning calls. Like, folks want to know, how do you fund these things? So, again, Lee, we'll start with you. And you already shared like this program is embedded within your city budget. But do you have any historical insight into even how maybe some of those decisions came about to include it in the city budget? Who might have been some partners or some champions that help support that?
Yeah, absolutely. I know that's a question we often get. So when the city manager at the time made the decision to create a new department within the city of Durham, that was a huge decision. Departments don't get created every day. And so with that, of course, there had to be a certain amount of funding dedicated to the new department. But even before that, what led her to make that decision was a recommendation from the Community Safety and Wellness Task Force, which was a task force that was convened to really look at violence in Durham, to really look at the 911 response protocols in Durham, to really come up with creative interventions that the city could potentially implement, and recommendations. So one of the recommendations was to create some sort of department that might respond to 911 calls. And so how that really took shape, happened after the department was created. But certainly the city manager saw the need for a department like this and dedicated the continued funding for that. And luckily, each year we have seen an increase in our funding allotment, which has allowed us to increase the number of responders that we employ. And as I noted previously, we have had a couple of different grant opportunities, but largely, almost wholly, we are funded by city dollars, which just means it's the same way any other city department is funded. That's kind of our main funding source.
Thank you. And Candace, if you have any insight into how STAR is funded, any historical information about how that came about, that'd be welcome.
Yeah, so during the pilot, our program was funded through a grant that's specific here in Denver. It's written into city ordinance, so 25 cents of every $100 in taxes goes towards behavioral health and alternatives to jail initiatives. And so during the pilot phase, the program was funded by that grant. And then since then, we've been able to expand. We're very fortunate to have a lot of support from, like I mentioned, the community, our community advisory committee, as well as city council. And so right now we do still fund a good portion of our program through the grant, and also about maybe 60% of it, I would say, is through the city general funds.
Very helpful. Thank you. Okay. So let's take another look at some of the questions that have come in. Let's see. Types of clinicians on both teams. So someone asked, are the clinicians exclusively nurses or social work or registered healthcare professionals? Candace, let's start with you.
So they're behavioral health clinicians, and in Denver for STAR and for co-response, they're licensed. So in Colorado, that means that they're able to provide those evaluations for the emergency mental health holds and to author them if someone is meeting that criteria.
And similarly, in Durham as well, we have clinicians, and for us, we define clinician as someone with a master's in either social work or licensed mental health counseling, psychology, but who has that background and training in as a mental health specialist. And as I mentioned, the state of North Carolina functions a little bit differently. So our clinicians in this state are not able to kind of do the involuntary commitment process, but certainly have the training to know when that's necessary.
Okay. Great. Okay. A really great question that came in was, how did you educate your community on these programs? How did you foster buy-in among your community? It sounds like on both sides, the community has really bought on to what you're providing. But initially, when you were just rolling out, what did those conversations look like? How did you foster buy-in for these new alternatives to calls for service?
Sure, I'm happy to start us off with that. We were incredibly lucky and privileged in so many ways to have the support of the community. Again, the department itself was created out of the recommendation of the task force, but that task force itself had a number of leaders within the city of Durham. And we had champions throughout honestly our entire existence. And at one point, the community kind of had a very grassroots campaign for the growth of our department as well. There were kind of yard signs that were created. There were, signs that were put up throughout the city to increase funding for our department in itself. And so again, we really spent a lot of time and energy in engaging the community initially and figuring out what they would like to see in a department like ours. We held a number of listening sessions in English and in Spanish, some virtual, some in person. And ask really detailed questions like, what do you want responders to wear? What do you want? What types of calls do you think are appropriate to respond to? What kinds of calls are not appropriate? And just really made a lot of our decisions based on that feedback. So I think that really also increased our buy-in from the community as well.
And Candace, what has community buy-in looked like there in Denver?
Yeah, I think we're incredibly fortunate that, the development and the ask for STAR really came from the community. And so we initially, we were fortunate enough to start out with that buy-in because it was community who was asking for a program like STAR. So yeah. And then our STAR Community Partner Network, those are organizations that are embedded within the community and are working with community every day and representing those communities that they're working with. And so they're also doing a lot of work and outreach. And we've increased the number of our presence in different events and community events and outreach related things.
Okay. Now, I have had a couple people ask about staffing. And so, that is a concern across the nation, challenges in staffing these kinds of programs, finding behavioral health clinicians, et cetera. So have you all had any issues in regards to staff hiring and retention? What has that looked like for you? This time we'll start with Candace.
Yeah, I mean, I would say that staffing is always a challenge. It's an ongoing challenge. And I do think it's something that programs across the country are facing. This is a very specific type of work. And I can speak for myself that when I went through school, one, programs like this didn't exist. And two, I think, you're not really introduced to the crisis world within mental health necessarily. And so it's very specific, and there is a lot of stress. And, we're combining the behavioral health field with the first responder field. And so it is very niche and takes a lot to have someone who is interested in doing this work. So I do think that that staffing is an ongoing challenge. And I will say that just within the behavioral health field overall, staffing is also a challenge. So
Yeah, I would echo many of the things that Candace mentioned. We have an amazing group of responders within the department, many of whom have been with us since our initial launch. And so we've been lucky to retain those folks. But as we grow, every year it gets more challenging to staff up. And with the wide disciplinary roles that we have within the department, we're hiring not only clinicians, but peer support specialists and EMTs for these very niche roles. I would imagine that when most EMTs are going through their training, they're not thinking that, oh, I want to respond to only mental health calls, or only quality of life concerns. So um, it takes a lot of effort to find that really special person who this is their calling. And the same can be said for our peer support specialist and our clinicians as well. This is such unique and new work, which I think is part of the fun of it, of really getting to figure it out together. But that's not for everybody. So it takes a lot of effort in navigating to find the right fit.
That's great. And I think both of you will have alluded to the fact that there was, kind of evolution in how law enforcement embraced the program and now is really engaging with your programs at higher rates, requesting your services now. What has it looked like specifically to build that collaboration with law enforcement? One person was curious if police unions had any involvement in that relationship. So just curious to hear how that worked out as this is certainly an adjustment for law enforcement to no longer respond to certain types of calls. So let's start with Lee this time.
Sure. We are not a unionized state, so Candace can take that, I'm sure. But so we, fortunately, unfortunately, haven't had a lot of those barriers as it relates to unions. But with regards to our involvement with the police department here, um, when our department was created, we had a new police chief who came on at the same time that our department was created. So I know that Chief Andrews at the time and Director Smith, who's my boss, really made it a priority to partner in a lot of the things that they were doing. So it really came from top down in the Durham Police Department that this was going to be something that was embraced and supported by the police. While there were certainly echoes of concern and there were certainly instances in which, things could have gone differently, overall and over the past several years, our relationship has broadened into a really important thing. And I think it is due to kind of the top-down approach and the embracing of Chief Andrews and Director Smith and their partnership. I know at every kind of event where they're together, they really make an effort to approach things from a mutual lens whenever possible, and that has kind of trickled down. And as you could see from the data previously, we are very consistently requested by the police department to support on calls that we wouldn't have automatically been dispatched to, and our relationships with them have really blossomed.
I would say again, I think for the STAR program, we were very fortunate because the co-responders had started 4 years before. And so we really already had that buy-in. And the Denver police chief at the time was a big supporter of a program like STAR to be launched and developed. And so definitely I think the co-responders maybe went through some of those initial challenges of getting, having law enforcement, getting used to having a civilian in their vehicle with them all the time. I will say though, just from my own experience, I think maybe initially it seems like what we do as behavioral health clinicians and what law enforcement does is very different, but there is also a lot of similarities, right? I think as clinicians who work in crisis response, we also have maybe a little bit of dark humor, but we're able to bring in like this is appropriate language. And so there's a lot of, things that can be used as a connection point. And so I think, again, in my experience, I don't think that it took very long for the officers to really realize like, we need this, right? Like we are not the experts for these types of situations, and these are not the types of calls that we should be necessarily going to. And like Lee mentioned, a good portion of our responses are also from law enforcement requesting us because they feel like we are a better response option and able to provide different resources that they're either not aware of or don't have access to.
That's great. And I really think that that's the beauty of what both of your communities have achieved is that collaboration and that understanding of there is an opportunity here to ensure that resources are used effectively and relieve burdens on our critical resources to keep them freed up for other situations. So I think you both illustrate that beautifully. Let's see, a couple more questions and then we'll move to the end. The data that you all collect and share is so impressive. And I think would be remiss to not mention that the HEART program has a data dashboard online that folks can access. So if you want to share a little bit about that, Lee and Candace, if you all have anything that's available online, I'd love to hear that as well. And if you could also just speak to what has it looked like to pull this data together and to make that available. It is impressive, and I think a lot of other communities would love to imitate what you all have achieved in terms of the data and sharing that, centralizing it, or collating it together and coming up with the outcomes. We'll start with Lee.
Sure. So we do have a publicly available dashboard. If you Google Community Safety Department Durham, it'll come up. And this maintaining this dashboard and all of our internal dashboards is a huge job. And really, I point to the importance of our ability to connect to CAD, which is a computer automated dispatch system that houses all of the 911 calls within the city of Durham, but in particular for our program. And we are able to directly connect CAD to Gelada, which is the EHR system that our teams use to write notes for all of the calls. So that connectivity allows us to then on the back end pull all of that data. And we use Power BI primarily to create all of our dashboards, but it really allows us to parse out, not only, our response time, not only the types of calls that we go on, but also the types of calls that we could have gone on. Let's say we had 3 teams working one day, so they're all tied up and they couldn't get to X amount of calls because, all of our teams were tied up that day. It allows us to predict how many units we might need in order to be what we call reaching like saturation or reaching all of the calls that our units are eligible for, but we can't get to due to our staffing levels currently. So it's really helpful as we think about our budget and we think about building our program in the future, but it's also really helpful on our day-to-day aspect of how many units do we need working today? What time makes sense for the call volume for the types of responses that our team responds to frequently. So having the ability to look into CAD at that consistent data and that year over data is incredibly important as we continue to build departmentally.
I will say, one, we are very jealous of Denver's public facing dashboard. And our hope is to have something like that someday. We are not quite there yet. As I mentioned, we've had a variety of different challenges just because of, having different services contracted out by different service providers and, everyone using their own EHR system, everyone using their own separate data collection system. And so we're hoping to streamline that. I know, as I had mentioned, we're bringing our clinical services of our responder for STAR in-house to the city. And we have been working on developing some internal evaluation processes to work towards having our own dashboard someday. But yes, we're very jealous of their very beautiful dashboard.
But you are collecting data, you are analyzing it. That's the most important thing. So yes, so appreciate all of the work that you both are doing on that. And so yeah, we'll end with just one last question. folks are saying, oh, I want to do this. I've been trying to do this. I've been trying to push my police department or my mobile crisis team to do something like this. Um, what might be one suggestion you'd have to help someone move the dial forward towards getting these types of programs in place in their community? I know that's a big question, but just curious, is that you all are in the trenches doing this? What might be, one thing that a person should be thinking about as they make efforts to set up a similar type program? Let's start with Candace.
Yeah, I mean, I would recommend trying to figure out. I think sometimes getting programs like these started has a lot to do with fear of safety concerns and, like, is it appropriate to send unarmed civilians to calls? And so my first recommendation, I would say, is to try and identify where the barriers are and maybe why things aren't moving, or why the police department or the 911 center or whoever is involved in making those decisions is hesitant to implement something like this. And then show them, the data from the programs that have been existing now. I think every time I do a presentation where I'm asked what is a success of the program, I'm always like, the fact that we're still here, right? Because I think a lot of these programs started out really as like in highly political times, and there was a big push. And sometimes it's really hard to have that sustainability. But what we're seeing, regardless of the community, regardless of the specific model and the type of responders, is that these programs are needed and they're beneficial. And everybody from the community, from other first responders, and, just everyone sees that benefit. And so show them the data and tell them that it is, working, right? It's needed. And so, and the safety concerns, I mean, firefighters and EMS providers have, they're also civilian, and they've been responding to situations without officers for many, many years. And then also within the clinical field, social workers and mental health professionals have also done in-home care, and actually did not have access to a police radio where the dispatcher knows where they are and can send them someone, right? And so I think sometimes when we think about the potential safety concerns, we're not really being realistic of, is that really, should we be concerned, right? There are a lot of measures that can be taken for those, to ensure safety, right? And there are a wide variety of calls that are definitely appropriate for programs like these.
I agree with everything Tanda said. But I would also just kind of doubling down on looking at the data for your particular city or kind of region, and really tailoring the ask to what the need is. So that looking at the types of calls that may be most appropriate for a program like this, as it depends on your area. That's something that I often talk with folks who are interested in learning more about our program. It's like, this is how we do it because this is what made sense for Durham in particular. So just figure out kind of what makes sense for your area. While also talking to your city leadership. Go to a city council meeting, talk with them about what you would like to see and why you want to see it. I think programs like this can be scary when you don't know about them. So encouraging your city leadership to learn more about the existing programs, to look at the existing data, and to talk with folks, do site visits, to have conversations, and learn more about it so that folks feel more educated in what's actually happening versus what they think a program like this might be like. So I think those would be my two takeaways.
Thank you so much. And also there are a couple resources being dropped in the chat. So thank you, Lindsay. She dropped a recommendation for the International Co-Responder Alliance. So if you want to look that up. And Brianna also dropped a link to the HEART dashboard that we were talking about before. So we do need to move on. We're almost at the end of our webinar. So we will be dropping in the chat Sam just dropped the certificate of attendance in the chat, so you can click on that and then follow your device's instructions to download it. And you do need to personalize it yourself with your own name. Our last poll just popped up. If you would like to provide us any feedback regarding other resources that you would like to see, we do take this information into consideration when considering and planning future work. And if you were maybe referred to this webinar by a colleague, but have not signed up for our newsletter, Sam just dropped the link in the chat. Or you can use your camera to pull up the QR code and sign up for the Gain Center's listserv. And this is where you would get notifications for all of our future webinars. We do disseminate a quarterly newsletter where we like to feature programs. We have featured STAR in a past newsletter, I'm not sure if we've featured the HARP program or not. It's been a while, but we do like to feature local programs so that you can learn more about what's going on in the field. And then we also share other resources that are being put out by SAMHSA's Gain Center through this newsletter. Next slide, please. And then if you do have any following questions that weren't, answered, or if you would like to have more assistance, here is contact information for the federal SAMHSA administration. And then at the bottom of the screen is contact information for the Gain Center. And we welcome you to reach out to us through our toll-free number or this website. We're happy to provide phone-based consultations for issues that you may have or questions you may have that you would like to have answered. So don't hesitate to reach out to us. And thank you so much to Lee and Tandis for this incredible information and the incredible work that you do day to day to provide these critical services to the community. We really appreciate your time and expertise, and wishing you all a great rest of your afternoon. Thank you. Goodbye.